Okay, so welcome everyone to the Orlando GI Journal Club. This is October 4th, 2023, from Orlando, Florida. So we have 3 articles today, 2 randomized trials, and a retrospective study that we'll be reviewing. So our first study is by Chen et al. And it's looking at camrelizumab with rivoceranib versus sorafenib as first-line therapy for unresectable hepatocellular carcinoma. This was a randomized phase 3 trial. So hepatocellular carcinoma accounts for 75 to 85% of primary liver cases, and anti-angiogenic tyrosine kinase inhibitors such as sorafenib and lenvatinib have been established as standard first-line therapy for unresectable hepatocellular carcinoma, with modest improvement in the median overall survival compared to placebo. Over the last 5 years, immune checkpoint inhibitors have emerged as new treatment options for advanced ACC. Immune checkpoint inhibitors combined with Immune checkpoint inhibitors combined with tyrosine kinase inhibitor has been shown to improve overall survival versus anti-angiogenic tyrosine kinase inhibitor therapy alone in advanced solid tumors. The aim of this randomized trial was to compare the efficacy and safety of anti-PD-1 antibody camrelizumab with VEGFR2 targeted tyrosine kinase inhibitor rivoceranib versus sorafenib alone as first-line treatment for unresectable hepatocellular carcinoma. This was a randomized trial. It was an open-label trial, phase 3 study. It involved 95 sites from 13 countries, and patients with unresectable or metastatic hepatocellular carcinoma who had not received any previous systemic treatment were randomized in a 1-to-1 ratio to camrelizumab and rivoceranib versus sorafenib alone. Median follow-up period was 7.8 months to look at progression-free survival, and the primary outcome measure was a combined endpoint of progression-free survival and overall survival. 272 patients were randomized to CAM with Rivo, and 271 patients to sorafenib. Patients over the age of 65 accounted for 30% of the patient population, patient cohort in the CAM with Rivo group versus 23% of the cases were over the age of 65 in sorafenib group. As you can see, the majority of patients were enrolled in Asia, 83% in both CAM, Rivo, and sorafenib groups. If you look at the AFP level, about 35% of the patients had AFP of 400 nanogram per milliliter or greater, and Barcelona Clinic liver cancer stage was stage C in 86% in the CAM-RIVO group and 85% in the sorafenib group. If you look at the Child-Pugh score, the majority were class A, with 5 points, and the remainder had class A with 6 points. If you look at the etiology of HCC, majority again were from hepatitis B, 76% in CAM-RIVO versus 73% in the sorafenib group. 59% of patients in the CAM-RIVO group had previously received local therapy for HCC versus 55% in the sorafenib group. So this is the primary outcome measure. This is progression-free survival in months on the left-hand side, and on the right-hand side is the median overall survival in months. And as you can see, the blue line represents the CAM-RIVO group, the red line represents the sorafenib group. And if you can see, the median progression-free survival was statistically significantly higher in the Camrevo group at 5.6 months versus 3.7 months for sorafenib, and that gives the stratified hazard ratio of 0.52, which was statistically significant with p-value of less than 0.0001. If you look at median overall survival, again, Camrevo combination is superior to sorafenib alone at 22.1 months versus 15.2 months, and this gives a stratified hazard ratio of 0.62 with a p-value of less than 0.0001. When looking at the adverse events, the most commonly encountered adverse events in both groups were hypertension, elevation in AST and ALT, and Palmer-Plantar erythrodysesthesia syndrome. If you look at the instance of any treatment-related adverse events, those of grade 5 were less than 1% in both groups. Grade 4 was encountered in 10% versus 4% in sorafenib, and the majority of adverse events were grade 1 to 3, which accounted for the remainder of the treatment-related adverse events. The limitation of this randomized trial is that this is an open label design, and most participants enrolled were in Asia and had hepatocellular carcinoma of viral etiology. And also, due to its study enrollment pattern, some patient subgroups were small in size, such as Black patients and Hispanic patients. So the take-home point from this randomized trial is that camrelizumab with rivoceranib was associated with a significant and clinically meaningful improvement in progression-free survival and overall survival compared with sorafenib with a manageable safety profile. And this supports camrelizumab with rivoceranib as the new first-line treatment option for patients with unresectable hepatocellular carcinoma who have not previously received any systemic therapy. Our next study was published in Gastroenterology. This is by Marchegiani et al. And this is looking at surveillance for presumed branch duct IPMN of the pancreas, looking at stability, size, and age to identify targets for discontinuation of surveillance. Worldwide increase of newly diagnosed pancreatic cysts in the last 20 years has raised important issues regarding the need for surveillance and intervention in these patients. Branch duct IPMN represent the vast majority of truly neoplastic pancreatic cysts, and understanding the natural history of these lesions is important for establishing a surveillance system. The International Association of Pancreatology guidelines recommend regular follow-up with clinical evaluation, imaging, and/or endoscopy and laboratory tests, with surveillance lasting until the patient is deemed no longer fit for surgery. Recent evidence has highlighted that most small and asymptomatic presumed branch duct IPMNs remain unchanged with minimal risk of evolving into invasive cancer. So the aim of this study was to identify patient groups harboring presumed branch duct IPMN at low risk of malignant transformation, in which likelihood of pancreatic cancer was no different from age-matched general population. This was a multi-center observational study involving 12 centers and 8 countries. This was a retrospective study, although they do say that the study is based on prospectively accrued in institutional databases from high-volume centers in Europe, USA, and Asia. Patients with presumed branch duct IPMN without worrisome features or high-risk schemata at diagnosis who underwent surveillance were part of the study. And they looked at clusters of individuals at risk for cancer development, and they were defined according to the cyst size and stability for at least 5 years. And then age-matched controls were used for comparison using standardized incidence ratios for pancreatic cancer. The median surveillance for these patients was 53 months in this study. This retrospective study comprised 3,844 patients. 60% of the patient cohort were women with median age of 66 years. The median surveillance period was 53 months. 45% of patients had undergone surveillance for greater than 60 months. The initial size of the cysts were medium of 12 millimeters. Small cysts were identified in 66% of cases. So small cysts in this study was defined as anything 15 millimeters or smaller in size. Worrisome features during surveillance was seen in 20% of patients. High-risk stomata during surveillance was observed in 1.8% of patients. Patients with this presumed branch duct IPMN did not develop worrisome features or high-risk stomata for the first 5 years in 42% of the cases. 4.3% of these patients underwent surgery. Now, in patients who underwent surgery, invasive cancer was found in 16%, high-grade dysplasia in 16%, and low-grade dysplasia in 68%. Malignancy during surveillance in patients who did not undergo surgery occurred in a very low proportion of these patients, 0.4% or 14 patients out of the 3,844. In patients who did end up being diagnosed with invasive carcinoma during their surveillance period, the majority of patients were stage 1, A and B, which accounted for 55% of the cases, and stage 4 metastatic cancer was seen in 4.2% of the patient cohort. This table looks at the rate of development of worrisome features and high-risk stomata after the 5 years of stability. So if they look at overall patients who remained stable during the 5 years of stability, so that accounted for 1,617 patients out of 3,800 patients initially included. In jaundice developed in 0.3%, ductal dilatation of at least 10 millimeters in 0.7%, mural nodules in 1.2%, cyst size of greater than 3 centimeters in 7%, thickened cyst wall in 1.5%, presence of mural nodules in 1.7%, and ductal dilation less than 10 millimeters, so 5 to 9 millimeters in size, was 4.1%. If you look at a CA99 level of 37 units per liter or greater, that was counted in 4.3%. In this cohort, if these patients did undergo surgery, invasive cancer was found in 0.6%, high-grade dysplasia in 0.9%, low-grade dysplasia in 2.5%, and malignancy during surveillance in 0.2%. Also, in this cohort, who remained stable after 5 years stability, worrisome features were seen during surveillance in 14.5% and high-risk stomata in 1.9%. When they performed a further subgroup analysis to look at patients who were over 75 years of age, if you look at the development of worrisome features, that happened in 18%, high-risk stomata in 1.9%, and malignancy during surveillance in 0.2%. Now, if you look at the subgroup of people with really small cysts, so less than 15 millimeter in size, and over the age of 65, if you look at the development of worrisome features, it was in 6.8%, high-risk stomata 0.6%, and no patients in this group developed invasive cancer. These authors then performed standardized incidence ratios of different branch duct IPMN subgroups of pancreatic cancer. And this is when they look at the risk of these patients and compare it with age-matched cohort to look at and compare the risk of developing cancer compared to an age-matched population, i.e. population without branch duct IPMN. So when they look at all the patients, so 3,844, the standardized incidence ratio for developing pancreatic cancer was 4.65, with 95% confidence interval, or 3.3 to 6.3. When they look at non-trivial cancer, non-trivial branch duct IPMN, so these are patients who did develop worrisome features or high-risk stomata during surveillance period. So that accounted for 2,227 patients. The standardized incidence ratio for developing pancreatic cancer was 9. Now, if you look at trivial branch duct IPMN, again defined as no worrisome features or high-risk stomata, so that was 1,617 patients. The standardized incidence ratio was 2.29, with 95% confidence interval, 1.2 to 3.9. But if you further look into the subgroups of these patients with trivial branch duct IPMN, but they were less than 15 millimeter, less than or equal to 15 millimeters, the standard incidence ratio 0.93. If you look even further at trivial cysts in patients aged greater than 75, the standard incidence ratio was 1.12. If you look at those aged at least 65 years and really small cysts, but with no stomata, a high-risk stomata or worrisome features, the incidence ratio was 0.95. If you look at those greater than 75 years, standard incidence ratio is 1.12. So the limitation of the study is that it's a retrospective study, although it does rely on prospectively maintained database, and there is a relatively limited follow-up of surveillance patients with a median follow-up period of 58 months. So the take-home point from this study is that the risk of developing pancreatic cancer in presumed branch duct IPMN without worrisome features or high-risk stomata after 5 years of surveillance is comparable to general population, depending on the cyst size and patient age. So surveillance could be discontinued after 5 years of stability in patients older than 75 with cysts less than 3 centimeters, and in patients over the age of 65 who have small cysts, so those 15 millimeters or less or smaller. Our next study is looking at mepolizumab for treatment of adolescents and adults with eosinophilic esophagitis. This is a multi-center, randomized, double-blind, placebo-controlled clinical trial published in Gut by Dellon et al. Eosinophilic esophagitis is a chronic Th2-mediated allergic disease with pathological eosinophilic infiltration of the esophagus and symptom of esophageal dysfunction. Cytokine IL-5 has been thought to play an important role in the pathogenesis of EoE, and mepolizumab is a recombinant monoclonal antibody that binds IL-5 and has been FDA approved for treatment of other eosinophil-related disease processes such as hypereosinophilic syndrome, eosinophilic asthma, eosinophilic granulomatosis with polyangiitis. The aim of this randomized trial was to determine whether mepolizumab is more effective than placebo for improving dysphagia symptoms and decreasing esophageal eosinophil count in EoE. So this was a randomized trial. It was double-blind, placebo-controlled. They enrolled patients aged 16 to 75 years old with EoE and dysphagia symptoms per the EoE Symptom Activity Index. This trial was conducted in 2 parts. Part 1 was comprised of 3 months, where patients were randomized to either mepo or placebo. And then in part 2, the mepo group continued with their treatment, and placebo group were treated with the active drug mepolizumab. The primary outcome measure was change in EoE Symptom Activity Index at 3 months. So this study comprised of 66 patients, 34 randomized to placebo, 32 patients randomized to mepolizumab. The mean age was 33 in the placebo group, 38 in the mepolizumab group, 53% in the placebo group are men, 66% in the mepo group. 85% in the placebo group had also other atopic conditions such as asthma, food allergies, atopic dermatitis, allergic rhinitis, and pollen food allergy syndrome. 84% in the mepo group also had coexisting atopic conditions. When looking at the EoE history characteristics, the symptom length prior to diagnosis was 5.8 years in placebo versus 7.4 years in the mepo group. EoE duration from diagnosis to enrollment in the study was 6.4 in the placebo and 7.3 in the mepo years in the mepo group. Prior EoE treatments comprise of PPI, topical steroids, diet elimination, montelukast, biologics from prior clinical trial use, and endoscopic dilation. 88% in the placebo group had a prior topical steroid, and 50% had prior non-response to the steroids. Diet elimination was tried in 62% of placebo, montelukast in 18%, biologic in 9%, and 68% had undergone dilation. This is in comparison to the mepo group, where 81% had been tried on steroids, with again 50% prior non-response. Diet elimination was tried in 69% of these patients, montelukast in 19%, 22% had tried prior biologics, and 78% had undergone a prior dilation. The baseline EoE symptom activity index score was mean of 52.3 in the placebo group versus 55.6 in the mepo group. Endoscopic findings in the placebo group included 88% at exudates, 82% with rings, 94% with edema, 94% with furrows, and 59% with stricture. In the mepo group, the 78% had exudates, 81% with rings, 88% with edema, 69% with strictures, and 97% with furrows. The baseline peak eosinophilic count in the esophagus was a mean of 147 per high power field in the placebo group versus 112 in the mepo group at baseline. So 33% in the placebo group and 31% in the mepo group were able to complete the study. At end of 3 months, where patients were randomized to either placebo or mepolizumab, the baseline symptom activity index score was similar, with index score of 44 in the placebo versus 39 in the mepolizumab group. This is p-value of 0.22. When looking at change of score from baseline, it was 8 in the placebo and 15 in the mepolizumab. Again, p-value is not statistically significant, with a p-value of 0.14. When looking at those who were in clinical remission, it was 6% in both groups. So again, p-value of 0.95. And we're looking at decrease in score by more than 20 points. This is 21% in placebo versus 35% in the mepolizumab group, with p-value of 0.2. When looking at the endoscopic severity score, post-treatment, it was 5 in placebo versus 4 in the mepolizumab, and p-value of 0.03. So it was better in the mepolizumab group post-treatment. When looking at stricture diameter post-treatment, it was 14 millimeters in the placebo and 13.5 in the mepo group after treatment. When looking at peak eosinophilic count, post-treatment was 163 in placebo but much lower, and statistically significantly so, 35.7 in the MEPO group with a p-value of less than 0.001. When looking at histological response, less than 15 eosinophils per high-power field was seen in only 3% in placebo versus 42% in the MEPO group. And again, this was significant improvement in the MEPO group compared to the placebo. So at 6 months, so this is when, again, from month 4 to 6, patients in placebo will get MEPO, and MEPO group continue with MEPO. When looking at the symptom score at 6 months, again, no statistically significant difference, 33.9 in placebo and 36 in the MEPO group, p-value of 0.67. And this is a graphical representation of the symptom score over the 6-month period in this randomized trial. And they are similar with significant overlap between the two groups throughout the 6-month period. Adverse events were encountered in 71% in placebo, 47% in the MEPO group in the first 3 months. And then from month 3 to the end of the study, it was encountered in 79% in placebo and 64% in the MEPO group. The most significant and common adverse event occurring in at least 5% of patients was injection site reaction and injection site bruise. The limitation of this randomized trial is that it's a small study, 66 patients in total. And also the authors note that patient population was on a severe spectrum for EoE. And they had experienced treatment failures before and was refractory to a number of prior therapies. And therefore, it's not clear how mepolizumab would work in a less severe population. The majority of patients were above 18 years. So again, this data cannot be extrapolated to a pediatric population. And in the second part of the trial, all patients knew that they were receiving the active medication, and therefore symptom outcomes should be interpreted with caution. So the take-home point from this randomized trial is that mepolizumab did not achieve a primary endpoint of improving dysphagia symptoms compared with placebo. And while the eosinophil count and endoscopic severity did improve with mepolizumab at 3 months, longer treatment did not yield additional improvement. So to recap, camrelizumab with rivoceranib was associated with significant and clinically meaningful improvement in progression-free survival and overall survival compared with sorafenib, with a manageable safety profile. This supports camrelizumab with rivoceranib as the new first-line therapy option for treatment with patients with unresectable hepatocellular carcinoma who have not previously received any systemic therapy. The risk of developing pancreatic cancer in presumed branch duct IPMN without worrisome features or high-risk symptoms, high-risk martyr after 5 years of surveillance is comparable to the general population. Depending on cyst size and patient age, surveillance discontinuation could be justified after 5 years of stability in patients older than 75 years with cysts less than 3 centimeter size, and in patients at least 65 years old who have cysts less than 15 millimeters. Mepolizumab did not achieve the primary endpoint of improving dysphagia symptoms compared with placebo, and while eosinophil counts and endoscopic severity improved with mepolizumab at 3 months, longer treatment did not yield additional improvement. Thank you very much again for joining us this month. Our next journal club is November 1st, 2023. Thank you so much. Hope you have a wonderful day, week, and month, and I'll see you next month. Thank you so much, everyone. Goodbye.